It's my pleasure to talk to you about the simple way of doing a bicuspid valve repair. It's pretty straightforward. And so I'll show you two cases with some of the nuances on bicuspid valve repairs. The keys are understanding the anatomy, and we have a way and a sort of schema that we work through to do that. And I'll show you more of that later. And the two patients illustrate, first of all, the simple bicuspid valve repair, and then how you combine that with other procedures, in this case, a root remodeling operation. And you'll see also in the typed notes, the text, some more details about the procedure and the steps we take to make a successful repair. So with that, this is a young 27-year-old patient with severe aortic valve regurgitation from a bicuspid valve, and there's prolapse of the leaflets, lack of coaptation, and also a area where there is not a conjoint and symmetrical fused leaflet. So first thing here is to look at the valve and understand the anatomy. Remember that from the echo, that's usually not very good. My first step is to divide the raphe in all these patients and to free that up so you have a leaflet that's mobile and is going to coapt well. So the raphe has been cut away there. Then the next step is to put the valve sutures, the Cabral sutures, into position to bring the leaflets together to get the apposition better. And then from that, you then can start estimating what you need to do. Now, I hook this onto my retractor. This is a min-invasive operation, as you see, so limited exposure. This is probably about a 6 centimeter incision. And here's now the leaflet being coapted down at the base of the commissures, and this is coming out there. Obviously, you've got to watch out for the left main. And so this is the second valve suture or Cabral suture. And I always tell the nurse I need the valve sutures so they know that this is for the Cabral stitch. So there's now that valve on tension, and the key throughout the process, as you'll see, is to stretch those leaflets so you have an understanding of how much plication you need to do. Now, many years ago, we did a study here from the Cleveland Clinic showing that plication has a much better durability than resection and sewing the leaflets together. And obviously the problem is that these leaflets can tear. Now, over many years of experimentation, in a sense, and trying different techniques, I find this 5-0 Ethibond is the best suture for repairing the incomplete fusions of the leaflets or prolapse, and stick to the thick parts of the tissue. For whatever reason, the tissue on the right side of the commissure tends to be a bit thicker in most of these patients. So I tend to not make this plication always central, but perhaps a bit more towards the right coronary part of the leaflet. And then I lock the sutures, and you'll see in a moment the reason I do that is that I can put the progressing repair here under tension to get a better idea of what it's going to look like. And so the next step now is to assess how much I still need to plicate there. And you never want to overdo it, because then you end up with aortic valve stenosis. And the other thing is I use this horizontal mattress suture here because I hope it's less likely to tear out, and I haven't seen it tear out. And so in a sense, you're buttressing more tissue here than with a running suture. And so you then tie that down, and this then should be your final stitch as far as getting that leaflet symmetrical. And there you see it's symmetrical now. You got the right tension. Then I have a look to make sure I have a large enough opening. I'll often put a hay gauze in there to make sure that I have a big enough opening for the patient's BSA. So having done that, then the next step is the Gore-Tex Suture. I used to have used the 5-0 Ethibond for this, but I stopped that many years ago because I had a patient where the Ethibond tore through. I think the Gore-Tex, the PTFE, has got a bit more springiness maybe to it, and it's just a bit thicker. And I think because it's not a multi-filament suture, it's less likely to saw through the tissue. And then we put a pledget on this to anchor it so that it doesn't tear through the aorta. If you don't do that, particularly if the sutures are close together, you may have some bleeding from this figure 8 suture. So external pledget helps. And then I put clips on that so it doesn't unravel, because one of the problems with Gore-Tex, as you know, is it can unravel. And then we're going here to the non-coronary left commissure, and same thing, hitching it up so you increase the amount of approximation of the leaflets. Depending if I think there needs some slight adjustment, I might put this off to the one or either side when I tie this down to pull the leaflets in a certain direction. And here you see I've pulled it slightly towards a non-coronary sinus, both figure of 8 suspension sutures. And as you see, that now tucks it in at a higher level. And if you look there, you can see there's a lot of height of approximation of the leaflets. And again, what we do is make sure that this is looking good and symmetrical. And if there is any thickening of the non-coronary leaflet, in this case, I will either shimmy that or crush that area so it folds more well into the leaflet that has been sewn together. So if you look there, there's a bit of thickening on that leaflet there. So I'm just going to soften that up a bit so that it approximates better with the other leaflet. And so there you have a nice symmetrical repair that should work very nicely. And so you then start closing up. In this patient, the ascending aorta was a bit enlarged, but not enough to replace it. And so from that point of view, I'm just going to do aortoplasty. We've just done a study on a big series of patients with 400 patients in each group, looking at ascending aorta replacement with bicuspid valve repair versus only bicuspid valve repair. And while I thought the benefits may be there for replacing the ascending aorta in these patients who need it, we don't see any difference in long-term durability in the repairs. Both methods coming in at about 95% freedom from reoperation at 10 years. So there's just a piece of aorta being cut away, and I make a sort of S-incision when I do the aortoplasty, and then complete the repair of the ascending aorta. So here's the post-procedure echo with no leakage from the valve and a nice approximation of the leaflets with a good opening, and the gradients were very low. And so hopefully this is going to hold up well for the patient long term. We have about a 2% to 3% failure rate in the first 1.5 years after the repairs. And the gradients also go down with time. So the lowest gradient, typically after repair, is about 18 months after the repair, based on our own research. So if you have a slight gradient, don't be too concerned about it. Don't abandon the valve because of that, because over time, as the inflammation, etc., gets absorbed, that seems to improve. Obviously, if you've got a severe stenosis, then that's not a valve you should be keeping, and you shouldn't have made it so tight that you have a severe stenosis. So we will then go ahead and also just show how using this repair can be used for remodeling operation. It's important to leave a good cuff at that non-coronary sinus. Then the principle is going to be always making the bicuspid valve symmetrical, and so tension sutures to maintain tension on the commissure is important. And here some silk sutures are being used to put tension on those commissures. The other thing that I use is an inclusion technique for the coronary artery, so you don't excise the buttons as you would say on a reimplantation operation, but leave them in place, and you'll see how that becomes later. So here we now give antegrade osteocardioplegia to get cardiac arrest, since this was a patient with aortic valve regurgitation and a regurgitant valve. I usually have a retrograde cardioplegia available on these patients. So one of the first steps is to free up the RAF, and I excise that as much as possible. And here we're just measuring the length of the leaflets, and so inevitably you end up using the largest graft possible, whether that's a 34 or a 38. Then the next step is to put in the Cosgrove sutures to improve the intercommissural angle, to narrow that down and improve apposition of the leaflets. So for the Cosgrove sutures, put them more into the aortic tissue, not too close to the annulus, and tie those into position. And notice there's a small fenestration there at that commissure, but that won't be a problem once you narrow the intercommissural angle. And there you see tension on that Cosgrove suture and on the other one. And now you can begin to work on making sure you have symmetry of the two leaflets. And so there you can see there's a bit of prolapse potentially there of the middle of the conjoint leaflet. So the next part then is to start preparing the route for the remodeling operation. We've got the Cosgrove sutures in place, and then dealing with any minor fenestrations. That sort of fenestration really isn't a problem at all. You can certainly be more lenient with fenestrations in young people because it's so much more important that you keep the valve for them. So you see there the edge of the tube graft, and you cut the openings to the tube graft, and make sure that the openings for the commissures are high. In other words, you don't want any tension on the annulus in the middle of the sinuses. You want all the tension to be on the commissures, the apex of the commissures within the root. So there you just briefly saw the tube graft that had been cut to accommodate that. Then we put in these Gore-Tex sutures at the leading edge of the commissures, and we're going to do an over and over figure of 8 suture there, and then hitch it up on the outside of the aorta to bring the height of the leaflets to a higher level. And we've shown that this improves the durability of repairs long term, not only for 3-leaflet valves but also for bicuspid valves. And notice that's about 3-4 millimeters higher on the aorta, and most of the time I put a pledgeted suture onto that just to make sure it doesn't pull through the aorta, because the tension is fairly significant. on these Gore-Tex sutures. I used to use Ethibond, but I stopped using that because I had one patient where the repair failed and the Ethibond had torn through the leaflet, but after I started using Gore-Tex, that hasn't occurred. And maybe it's because there's a slight elasticity or it's less of a cutting suture. It certainly seems to work better to use Gore-Tex for these sutures. And then because there's a lot of tension on the suture and there's a risk of unraveling, I'll put a clip on that knot just so it won't unravel. So there you see how that leaflet's been hitched up to a higher level, and we're going to then do that on the opposite end. And again, we're working towards a nice symmetrical bicuspid valve. So if you look at that suture, the first bite tends to go a bit further out on the leaflet, and then the second one is closer to the aortic wall. And I will sometimes adjust a prolapse in the leaflets by moving the place where I implant this from either side. So in this case, I'm putting it just a bit more towards the right, in other words, to the non-conjoint leaflet to see if I can hitch up that leaflet a bit higher, depending on how much prolapse that there is or whether it's an incomplete leaflet, and maybe avoid having to put a plication suture in the middle of the leaflet. In this case, we're going to need to do that. So just a bit too much prolapse on the conjoint leaflet between the left and right cusps. And again, just a clip on that to stop it from becoming unraveled. And we'll now have a good look at things here and see how symmetrical the leaflets are. So using two forceps, I do that a lot to check on the symmetry of the leaflet during operation. Another point that I've made before is, for whatever reason, the thickest part of this conjoint leaflet tends to be towards the right side. And so it's typically not right in the middle of the leaflet that you do your plication. It's a bit more towards the right coronary artery ostium. And although I typically do a running suture for an incomplete fusion, in this case, because it's just a little prolapse, all you need to do is tighten that up by 1 millimeter or 2. I use a horizontal mattress suture, and that's what I typically use as the finishing, even for a largely incomplete leaflet. I think the security of that as far as tearing out is much better than just an over and over suture alone. And again, this suture is a Ethibond, it's not a Gore-Tex suture. So there's application now, and there's the symmetry to the leaflets. You'll see the heart moving every now and again. We're doing a research study on ventilation of lungs during cardiopulmonary bypass. So next is to bring down then that beveled tube graft. And as I emphasized, this is the biggest that's available. So I usually start somewhere near the raphe. The tissue is a bit thicker there and stronger, and that's more or less the middle of the position on the tube graft also. So usually about 3 or 4 rungs of the graft, and notice how I put the needle through the cabral pledget, so that original pledget for the cabral, put it through that, and that means that you have a circumferential anchoring of the annulus at the other commissure between the non coronary in the left. Make sure that you've got lots of tension on that commissure, and then put it through that pledget for the figure of 8 suspension suture, so that you've got lots of tension on the commissure. And then we're going to do the same thing here, so tucking it in there, and then again we're going to put the final sutures here through that cabral stitch pledget to make sure that you have a circumferential strengthening of the annulus. So the tension on the annulus is taken up by the graft and then by the cabral sutures. And where I've seen remodeling operations fail, it's been at the commissures, and so that's why it's important that you, in a sense, close this off so it's not a potential site for later stretching. It's important also that you don't go into the ostium of the coronary artery, because that's very fragile tissue and you don't want to put a lot of tension on that. So once you've done the posterior wall, then you move around, do the anterior part of the button, posterior wall first. So once you've completed that, check that there's ostia open, check your valve, and then you can run antegrade quadriplegia into the root and down the coronaries, clamp the graft with a Fogarty clamp, and now you can check for hemostasis again. There's slight bleeding there, and I'll show you then how to deal with that. And then once again check the non-coronary sinus. So using the inclusion technique, it's very easy then to get hemostasis if there is any bleeding here by putting a couple of horizontal mattress sutures through the edge of the coronary ostium button and through the aortic wall, and you just seal that whole area off. And there you see that sealed off.